And welcome. Welcome to this segment of The Half Has Not Been Told, which is a two-part series sponsored by the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services. It is a segment or series that we put together to shine a light on persons with lived mental health, developmental disabilities, substance use disorders, and traumatic brain injuries, to shine a light on their experiences during the COVID pandemic. Oftentimes, we tend to think about this COVID pandemic in the terms of a public health crisis or a medical crisis. And very often, we forget that there's also what we call a parallel pandemic that is also happening, and that is increases in mental health, increases in substance use disorders, increases in challenges that persons with IDD, which is intellectual and developmental disabilities, and also traumatic brain injuries have also endured during this pandemic. For example, if you take a look at the data, we know that during this pandemic, we've seen an increase in persons reporting, adults in particular, reporting increases in mental health or substance use. For example, a survey that was done, a cross-sectional survey that was done in 2020, that took a snapshot of where people were in terms of their mental health and substance use issues or conditions during the pandemic. In June, 40% of U.S. adults reported struggling with mental health or substance use. Specifically, 31% reported experiencing anxiety or depression. 26% reported experiencing trauma or stressor-related disorder symptoms. 13% reported that an increase or a begin or start of using substance use, and then 11% seriously considered suicide. We also know that when we look at our children or young people, when we look at adults compared to young people, that young people are also experiencing increases in substance use disorders. So what we want to do today is to have a conversation. We had a conversation on the first series with persons with lived substance use, mental health, traumatic brain injury, and IDD conditions. What we want to do now is have a conversation with providers. And the slide that you're seeing now just shows where North Carolinians are compared to the rest of the country. North Carolinians, again, just a snapshot, right? Things change, but through April 28th and through May 10th of 2021, 33.5% or 34% of North Carolinians reported symptoms of anxiety or depressive disorder. If you refer back to the first segment, you will see this detailed presentation. But what we'd like to do is to go ahead and have a conversation with those that we have invited who represent the provider association community as well as the advocacy communities. And particularly, we have joining us today people who represent substance use disorders, IDD, mental health, and traumatic brain injury. The first panelist, I am so excited, who will be joining us in this conversation is Curtis Taylor. Curtis Taylor is the Executive Director for the Alcohol Drug Council of North Carolina. And for many years, Curtis Taylor has been a voice for citizens seeking long-term recovery from substance use disorders. He served as an appointed member of Governor Pat McCrory's task force on mental health and substance use disorders, and he has served multiple terms as a chairperson for the North Carolina Substance Use Disorder Federation and as a member of the North Carolina Departmental Waiver Advisory Committee known as DWICE or DWAC. And he is a member of the board of directors for I2Y Center for Integrative Health and a board member for the Emerald School of Excellence, the First Recovery High School in North Carolina. Mr. Taylor is also a person in long-term recovery, and for him, this means that he has not used alcohol or any other substance since December 23rd, 2002. Yay, we applaud that. He obtained his bachelor's degree in social work from Shaw University in May of 2019. Shaw is one of North Carolina's 10 historically black colleges and universities. Presently, Mr. Taylor serves as the executive director of the Alcohol Drug Council of North Carolina, and also he is committed to making their information referral hotline, perinatal services, National Guard screening, brief intervention program, and prevention services the best in the country. Under Mr. Taylor's leadership, the council respects and embraces all pathways to recovery. He is committed to the elimination of stigma attached to the subject of recovery, and he is an extremely vocal advocate for all citizens faced with the challenges that accompany substance use disorders. Mr. Taylor is proud to serve at the ADCNC. We also have with us on the panel today, Sarah Pfau. She is the Senior Consultant for Cancer Collaborative Resources. Sarah has worked in health policy and health law for nearly 30 years in the national nonprofit academic worlds, as well as public interest law, private sector, and state government venues, including 6 years of regulatory work in the North Carolina Medicaid and CHIP, which is the Child Health Insurance Program, programs in North Carolina. As a senior consultant with Cancer Collaborative Resources, Sarah works with diverse clients in the dynamic landscape of North Carolina's Medicaid transformation. Sarah helps manage a statewide nonprofit association for behavioral health and IDD providers, the North Carolina Providers Council, and serves as a liaison with state government officials, LME MCO, CEOs, and collaborating provider and consumer advocacy agencies. We welcome Sarah as a panelist today. Also, we have with us John Nash. John is the executive director of the ARC of North Carolina. John has been the executive director of the ARC of North Carolina since 2014. Prior to that, he was the executive director of a provider agency serving people with intellectual and developmental disabilities in Central California. He holds a BA in Political Science and International Relations from Brigham Young University and a MA in Administrative Leadership from Fresno Pacific University. He has had long involvement with crafting, assessing, and promoting public policy initiatives on a variety of issues. In addition to his work leading nonprofit organizations, John has extensive experience as a management and organizational development consultant, doing economic and community development, and working on K-12 education issues. John pens an occasional blog, The Uptight Executive, which I love, sharing insights, tips, and advice gleaned from 30 years of nonprofit experience. Whatever spare time he has left, he spends with his wife and sweetheart of 36 years, entertaining grandchildren and building odds and ends in his home wood shop in that order. We welcome John as a panelist. And then Valerie Arndt. Valerie is the executive director for the National Association of Social Workers here in North Carolina. Valerie, pronounced Arndt, is a social worker and the executive director of the National Association of Social Workers North Carolina, and she leads the association efforts to advance the profession in social work in North Carolina by advocating for social work issues such as the hiring of degree freed social workers in the public and private sector, higher salary and reimbursement rates for social workers, and the advancement of social justice and social welfare issues. Valerie is also the chair of the North Carolina Coalition on Mental Health, Developmental Disabilities, and Substance Use Services, a coalition of organizations representing consumers, families, advocates, providers, and professionals who are committed to assuring the availability of services and supports for North Carolinians who experience addictive disease, mental illness, and developmental disabilities in North Carolina, and for the millions of family members, friends, and others whose lives are also affected. Thank you all for agreeing to be panelists today on this second part of The Half Has Not Been Told. During our first segment, as I mentioned, we talked with and had on the panel members of the lived experience community. So we are glad to now shift the conversation a bit and hear the perspective of providers and advocates, and not to suggest that persons with lived experience are not advocates in their own right, and we certainly saw that in the first segment. But many of you professionally advocate for services and supports for the workforce as well as those who are served in our mental health, substance use, IDD, and traumatic brain injury public system, which is where I hail from the division. So today's conversation is extremely important because it gives us an opportunity to talk about, one, the workforce that is serving some of North Carolina's most vulnerable people who require on systems working right and effectively, people who require trained workforce, people who require systems of accountability. And each of you sit at the table bringing your unique skills and talents into this conversation, as well as your expertise. And so I want to start, one, just with an open question, an introductory kind of question to allow each of you to sort of talk about what your organizations have done, what you are doing during this pandemic, and to start us out with giving us a perspective, just setting the context for this conversation using the lens that you each individually have. And so we will start first with Curtis. We know that the substance use population has experienced a great deal of instability in our system, right? In terms of funding or lack of funding, in terms of services or lack thereof. And so when this pandemic hit, it hit at a time that we had a great need for more community supports, more community-based services, and also a great need to work through dismantling the stigma that keeps some people in out of recovery. So Curtis, I would like for you to share with us, from your perspective as the executive director of the Alcohol and Drug Center of North Carolina, what are you seeing and what has your organization seen during this pandemic that we really need to zero in on, and tell us some of the work that you have done to address some of it?
Yes, good morning, and thank you, Dr. Laws. First, let me just start out by saying I'm truly honored to be a part of this panel. You folks look absolutely outstanding on TV, by the way. But yeah, it is truly an honor for me to be here. As far as the ADCNC, or the Alcohol Drug Council of North Carolina, one of the things I'll say right off the bat is that our numbers, our call volume has more than doubled. More than doubled from 2019 through the year 2020. The numbers skyrocketed. Obviously, there's been a lot of anxiety, a lot of trepidation in our society as a result of this pandemic, and that, of course, has led to a lot of self-medication. Humans naturally seek to feel more comfortable when they're placed in an uncomfortable position or situation, and a lot of folks seek after substances to try to fit that bill, unfortunately. And a lot of folks wind up finding themselves with an actual disorder or an issue with those substances. And that's where our agency comes in. So we operate statewide. We service all 100 counties in the state of North Carolina for any North Carolina citizen that finds themselves in need of services for substance use disorder. We're not married to any particular pathway to recovery. We embrace medication-assisted treatment, faith-based, smart recovery, 12-step, you name it. Whatever is going to help that particular individual in their particular situation is what we get people connected to. We are just simply a conduit that connects people to the vital resources that they need so desperately.
Great. Thank you so much. And we will come back with questions to sort of dig deeper into some of what we are seeing in terms of the doubling, as you mentioned, the call volume doubling, and talk about some of the specific programs and services and supports that can help us in North Carolina address those needs. I want to shift now to Sarah Fowl, and thank you, by the way, and forgive me for butchering the Alcohol Drug Council. I call it the Alcohol Drug Center. And I'm very familiar with with the work you do and your organization. But I want to shift now to Sarah and have you sort of tell us, you know, chair or lead the Provider Council and Providers Council, and you get to see and hear from providers from all across the state. And a lot of times it seems as if, or it could seem as if, those voices have not been heard or not attended to. So the council plays an important role in making sure that those voices are heard. So tell us what you are seeing and what the council has witnessed during this pandemic that we need to focus in on.
Sure. Thank you for having me today.
Yes.
We absolutely do work across the state of North Carolina. And as you mentioned, the Providers Council specifically has predominantly IDD provider membership, but we do also have providers who work in behavioral health and substance use disorder treatment. We also have what we call provider support members who work in the areas of the electronic health records and data storage and even housing supports for the provider agencies. Mm-hmm. And we also have some licensed independent practitioners. So we have a really diverse membership working in very different size and functioning provider agencies. So they've really witnessed throughout this pandemic certainly so much change, and I do have some slides to go over at some point today, but one of the things I focused in on the slides is the fact that there have been so many federal laws, regulations, guidelines, things at the state level too, coming from executive agency health officials, both at the federal and state levels, that our providers across the state and the health plans have had to track, digest, and focus on and ensure that they're complying with. And that has been a tremendous burden on them because their focus is rendering these services to the populations who depend on them. So it's been very administratively burdensome for our providers. At the same time, I would say that North Carolina, our state health officials in North Carolina have done a tremendous job in distributing information and being transparent and putting up dashboards for our providers to follow, in timely publishing evolving guidance for the providers that they've been able to follow. So that's been very helpful. And there's really been an open door for providers. The state stood up monthly calls, even weekly calls in the beginning of the pandemic for providers to express their concerns, whether they were policy concerns or operational concerns. And DHHS and the Division of Health Benefits and the Division of Mental Health really listened and responded to the needs. They worked with the LME MCOs, who, for the most part, especially in 2020, our providers were contracting with to offer behavioral health managed care services and IDD managed care services under waivers. Yeah. So that has been helpful for them.
Wonderful. And we'll go back to your slides a little bit. So I want to just go through first and get everyone's intro. And then I do want you to dig into your slides at a later time. And I apologize for
That's all right.
sort of stumbling through this. But Next, I would like to have John just sort of tell us about what the ARC does, John, what you all do, what you've been doing during this pandemic. And then we will go into, once we hear from Valerie, then we'll come back and dig deeper into the conversation where we know that you also have some slides that you wanted to discuss. But just tell us a little bit about the ARC and how you guys have been faring during this pandemic.
Well, thank you. First of all, appreciate the opportunity to be here with a really good group of people. And just a little quick background about the ARC. We've been in North Carolina since 1953, and the ARC is nationally one of the premier organizations providing services and advocacy with and for people with intellectual and developmental disabilities. And so it's about creating a stable and workable environment for people with IDD. That means providers and services have to be stable and accessible. And it has to be an environment where people can share their voices and be a part of what's going on. And in the IDD world, we have a saying, particularly for people with disabilities, nothing about us without us. And that's a complicated thing in a system where it is already complicated. We have a lot of things going on, a lot of moving parts. And then you throw the pandemic on top of that. And so over the last year in particular, a lot of things we've been involved in is ensuring that people with IDD have priority for vaccination, given that they have a much more adverse consequence if they are infected, and making sure that they were high on the list and not at the end of the list. We spent a lot of time and energy trying to ensure that people with the IDD, when it comes to limited medical equipment that's available, if there's only 5 ventilators available and 10 people need them, who decides who gets what? Well, up until January of this year, the decision was no matter what happened, somebody with IDD was not going to be top of the list. We would be at the end of the list. The formula was adverse based on criteria that is probably 60 years old. So spending a lot of time making sure that those things are addressed and that people not only have a voice, but have the ability to give a voice in a place where we couldn't really be in person and in those locations. I mean, that's because of weakened immune systems and very fragile circumstances. It's really hard for somebody with a disability to be able to be the voice that they choose to be. And so we spent a lot of time trying to cross those bridges and bridge those gaps, in effect, to make sure that people had an ability to speak and to be heard and to be addressed appropriately. And again, it's a complicated environment.
Yeah, very much so. And we're so glad that the ARC has stayed on the wall, so to speak, really making sure that the voice of the IDD community is heard and represented. And you're absolutely right. Starting out, as we moved into the pandemic, it really was, an interesting concept for us. It's thinking that the most needy was not those that, or the priority was not those that we would ordinarily give priority to in our space, in the space that we work in, right? So we will talk about some of that, but we did pick it up. We did eventually get it, but
and to the department's credit, I mean, it was very much appreciated that when we sat down and were able to look at the information and what was the adjustment was made, and it was very much appreciated.
That's right. And so we'll get to that in a little bit more detail. But I did want to say that we eventually got it right. And that's important. And that's why your voices at the table are important, right? Because you are charged with and challenged with making sure that institutions get it right, that systems get it right. So I want to shift now to Valerie. Valerie is a social worker and also represents the North Carolina Social Worker Association and the National Association of Social Workers, the North Carolina chapter. And I say I have a category of people that I place at the top of the list of who I think are certainly doing God's work. And I held them in high esteem, even higher than, elected officials and all of that. And it's doctors, ministers or faith leaders, school teachers, and social workers. These people in their respective professions are the ones that get to communities and marginalized populations when others cannot reach, and when others really, quite honestly, may not even have them on their radar for different reasons, right? But it's your job. It's their job. It's social workers' job to reach the marginalized populations. And so I'm so grateful for the work that social workers do and have done. And so, Valerie, tell us a little bit about what the association does, what your role is, and sort of how you've moved in this space during this pandemic.
Well, thank you so much, Dr. Laws, and it's a pleasure to be on this panel with my amazing colleagues, and thank you for the hype up of the social work profession. So the National Association of Social Workers North Carolina chapter works very hard to protect and advance the profession of social work. As you say, Dr. Laws, the social work profession works hard to meet clients where they are and serve the most vulnerable, oppressed populations, including those in poverty. So we work really hard to make sure that North Carolinians are receiving the services that they need and have their basic needs met. So the National Association of Social Workers is a membership association, and we represent members, social work members from across the state. There are 13,000 licensed clinical social workers in North Carolina, and as Sarah said, social workers work in all areas of practice, including behavioral health, which is mental health, developmental disabilities, and substance use services. But the majority of social workers do work in the mental health area. So social workers have seen the increase of need during the pandemic, and the increase in seeking mental health services came before the pandemic. So as stigma was decreasing and as there were a number of natural disasters across North Carolina, people were continuing to seek mental health services, which is great. Adults, 1 in 5 adults are having mental health issues, but only 40% of those individuals are seeking services. So social workers are really indeed at the front line serving individuals, hundreds of thousands of individuals in North Carolina. And so the National Association of Social Workers is here to support social workers throughout the state by advocating for them to ensure that they are reimbursed for their services, as well as making sure that they have the resources that they need to do the job the best that they can. So, which I'm going to talk about in a little while. During the pandemic, we have been advocating for the continuation of telehealth services. So with the extension and expansion of telehealth services during the pandemic, more client populations, more North Carolinians have been able to receive care, which is great. So we would like to see that telehealth services continue. And what I mean by that is before the pandemic, telehealth was not reimbursed at the same rate as in-person services. But because more North Carolinians are receiving services, we want to ensure that providers are being reimbursed at the same rate. A lot of insurance companies continue to extend that those telehealth rates, but we at the National Association of Social Workers will continue to advocate to make sure that is not only extended but permanently in place. So again, thank you so much for having me, and I look forward to continuing this conversation.
Thank you so much. We are honored to have you. Also, you all have heard from our esteemed panelists, and we want to jump in now and dig deeper. I want to go back to you, Curtis. I want to pull up a slide, and while the team is getting it together, it's from the original deck the introductory deck that I did in the first segment, and it's slide 9. That day that we did our first segment, the news had broke about the overdose deaths reaching 100,000 in 1 year. Mm-hmm. And I want to have you talk us through what some of the reasons you believe are, or some of the contributing factors to such a rapid increase. And it's slide number 9.
Yes. Is that the one you were looking for?
No, it's the one. It's the one that says the increase in overdose deaths. So it might not be. Yeah, but I want to, as they find it,
Okay.
it's just it's a snippet, a snapshot of. It's after that one, I believe. Oh. Okay. Well, I tell you what. Let's just have a conversation about it. It's
Yeah.
you know, it's sort of startling when you hear those numbers, 100,000 in
Yeah.
a year. And you talked about the doubling of the calls to your helpline. During this pandemic, are you seeing people navigate differently this pandemic than what they would have? Like, so I'm asking, is this like it's the way it is during any time of the year, right? That this isn't an anomaly, or is it really an anomaly? Like, are what we're seeing 100,000? Is that no big? That's it. Thank you. Is what we're seeing no big deal, or is it really a big deal because it's indicating something else going on other than the normal way people navigate through crises? For example, when we had hurricanes and natural disasters, I don't recall these kinds of numbers. So one could say, oh, it's just what we're seeing in a natural sort of disaster, a pandemic. But is it really, Curtis? What are we seeing here with this?
Yeah, absolutely. It is definitely a big deal. Just ask any family member of any one of those folks that unfortunately suffered an overdose, and they'll let you know that, yeah, it's definitely a big deal. What we've seen, Dr. Laws, I believe, has been almost a perfect storm in a very negative way, in that we were already dealing with a very fragmented system. Our continuum of care has always needed help, right? Not just in our state, but all across the nation, for that matter. We're dealing with a tremendous need, and there is a tremendous lack of resources to meet that need, and there always has been, probably always will be. But then when you combine that with COVID, so drug overdose deaths in the United States rose almost 30% in 2020. 30%. The capacity of our treatment providers to offer services was disrupted by COVID. In-person support almost just totally went away. Mutual aid groups came to a halt. Substance use disorders are often associated with multiple comorbid conditions that are also known risk factors for the most severest of outcomes when people get infected with COVID. The heightened stress and the isolation have also contributed to returns to use among people who are seeking recovery, and has accelerated the onset of substance-related issues and problems in an already vulnerable population.
Right.
So when you're dealing with a system that is already trying to, find its bearing and, crash down all the silos and the fragmented system that we're dealing with, and then you just plop this pandemic on top of it, people in recovery need each other. They need that social interaction. We've tried to deal with it with telehealth, as Valerie mentioned, meetings on Zoom and things of that nature. And certainly, yes, absolutely, we definitely need to continue with telehealth. Something is better than nothing. But that social interaction is of the utmost importance for people seeking long-term recovery.
That's right. And when you say that social interaction, that one-on-one direct contact with people, and we do know that loneliness is increasing, reports of loneliness, and that's creating, challenges for many people. Our seniors, I often say that, the social network for seniors was their faith community, their churches and their synagogues and their mosques. And when they couldn't go to the regular services and interact publicly and then face to face with people, that created isolation and loneliness, increased loneliness that triggered other, depression and anxiety and so forth. And we're seeing that across populations, children, elderly, persons in long-term recovery, people in recovery who said, I was in recovery for 30 years, 20 years, 15 years. And there was something about this pandemic and the way in which we responded to it that sort of triggered some of those same responses that led them into addiction.
Yes, ma'am.
So thank you for sharing that. And we're going to come back and talk about some other things that we know have been valuable. Telehealth, peer support in particular. But I don't want to go there just yet. I want to go to Sarah. And Sarah, please talk to us and share with us, what you think the main challenges are and where you think we need to really look at data-wise. And we know you have some slides, so we will now let you go through your slides and share with us.
Thank you. Yeah, when I was preparing to come today, I just thought about sort of 3 boxes for the providers. What were the challenges? And we have ongoing challenges still. What are the challenges? And what advantages and what assistance have providers and beneficiaries received during the pandemic? And then finally, now that we have a state budget and additional bills that have been enacted during the 2021 session, how is the legislation helpful, and what are some forthcoming policy and legislative priorities that maybe still need to be considered?
Yeah. So we'll go ahead. If you'll transition to the next slide, please. Yeah.
So the workforce crisis that has been mentioned briefly today has been very significant. There was a workforce crisis across direct care worker settings, whether it's assisted living, skilled nursing facilities, or the provider settings that I mentioned that are specific to the North Carolina Providers Council. This existed before the pandemic, and it was only exacerbated by the pandemic. So we not only had insufficient staffing and high turnover rates at the national and state levels, but DSP being direct support professionals, some people again prefer to say direct care workers, but the DSP wages, we had actually a pre-existing state-operated facilities wage disparity, beginning with legislation that was from 2018. Our state budget actually authorized a minimum hourly wage of $15. It was really an annual salary of $31,200, but that equates to $15 an hour. So that included the direct care workers in our state-operated psychiatric hospitals, our state-operated developmental centers. And then during the pandemic, we also saw competitive hourly wages appearing in retail and fast food settings, anywhere from $10 an hour to up to $20 an hour for hourly wages, for jobs that don't require, in some instances, don't even require a GED or a high school diploma. Your average DSP position requires a GED or a high school diploma, but that is the extent of the educational requirements. And in North Carolina, prior to the pandemic, our average hourly wage for DSPs was hovering around $10 per hour. So you can see why there are issues that were only exacerbated during the pandemic there. In addition to that, we also saw that we had staff, again, we already had staff vacancies, we already had high staff turnover rates, but during the pandemic, we had DSPs needing time out, whether it was for their own COVID-19 illness prior to the availability of a vaccine, or to care for someone else at home, or to quarantine or isolate during the pandemic. Some individuals may have voluntarily terminated their employment with our provider agencies prior to the availability of a vaccine because they were afraid to come to work. Yes, there was some PPE available, although we had PPE shortages across the state in the early months of the pandemic. And then even after the vaccine became available, we saw a problematic trend for provider agencies as employers with ongoing vaccine hesitancy among the direct support professional workforce. Another challenge, another sort of category of challenges that we saw for providers was the federal and state public health emergency powers. I mentioned earlier that there were so many laws, regulations, and sub-regulatory guidance for providers to track and comply with, both from the federal level and the state level. All state governments, state and local governments, have police powers, and those state police powers are authorized in the 10th Amendment of the United States Constitution. And so our governor and state and local health officials have the power to enact laws to ensure things like isolation, quarantine, public health measures, and health inspections happen at the state and local level. So we saw dozens of COVID-19 related executive orders that trickled down to providers and all other types of business owners as well. But these were to implement infection control measures, including the face coverings and social distancing and the visitation and gathering limits. Those visitation and gathering limits posed a problem in particular for IDD providers who operated day programs, whether on-site or off-site day programs, because they either had to temporarily or permanently shut down those day programs because people could not come together. The clients who were coming to the day programs could no longer attend. And I'll talk a little bit on another slide about some of the flexibilities that still ensured that some services reached those individuals who were receiving home and community-based services before the pandemic. But that was one area that really became problematic for the operations of the providers.
Next slide.
There's the last issue that has been, since we've seen the vaccine become available, the last issue was that we've also seen federal mandates, not state mandates. We have not seen any amendments to our state laws in terms of the compulsory vaccinations that we do have in place for certain first responders and school-aged children, both in public and private settings. But at the federal level, we've seen the Occupational Safety and Health Administration of the Department of Labor and the Centers for Medicare and Medicaid Services of the U.S. Department of Health and Human Services put forth rules, temporary rules, emergency rules, to enforce vaccinations among health care workforce employees. The Occupational Safety and Health Administration actually set forth two emergency rules. They're called emergency temporary standards. One was in June. That one is actually still in effect. And that one, although it did not mandate vaccines for provider agencies to enforce among their employees, it did mandate that the provider agencies pay for and allow for sufficient time off and pay for time off for employees to get vaccinations, and then if they had any adverse side effects after the vaccine, also to cover paid time off for that. But the OSHA ETS, the June OSHA ETS, primarily focuses on that infection control, just like we saw in a lot of our statewide executive orders. The physical barriers at workstations, sanitation, disinfection, ventilation, the use of PPE, the use of daily or shift-based screening, not COVID testing, but screening of employees to prevent infection in the workplace. So that is still in effect and did affect, in fact, many of our healthcare provider agencies. The newest regulations that we've seen, in early November, we saw published on the same day a new CMS rule and an OSHA rule. The CMS rule is about to take effect, as you can see on this slide. It requires, with the exception of any religious or medical exemptions among employees, it requires 100% vaccination in the healthcare facility, primarily healthcare facility settings that are subject to to conditions of participation with CMS to receive federal funding and state funding through the Medicaid program. So these provider agencies are now responsible for ensuring that all of their employees have had at least the first of 2 vaccination doses in a series by December 6th of this year, and the second dose by January 4th of 2022. This final rule listed here is under significant legal challenges from multiple multi-state legal actions, and it's currently sitting in circuit court in the 6th District Circuit Court of Appeals. And at this point in time, the Occupational Safety and Health Administration has put implementation on hold until these legal proceedings can be resolved. So we don't know where that's going to go, but that particular rule would ultimately require employers across all industries, not just the healthcare industry, to have all of their employees vaccinated or provide weekly negative COVID tests and wear face coverings in the workplace. And that would be for all employers with 100 or more employees.
So, Sarah, before you get to your next slide, for those who are not policy wonks and who don't get in the weeds of the policies, right, one might say, well, why is that a problem? Why is that a challenge? You have it listed on your slide identifying the challenges, right? So can you address that question that we hear often? Why is that a problem? Why shouldn't facilities that in particularly are housing and providing care to medically fragile individuals not be required to have a vaccinated workforce? Why or labor force? Why is that a problem? Will you explain that to the non-policy and data wonks?
Yes, certainly. As I mentioned earlier, for one thing, with the workforce crisis and the known vaccine hesitancy among the DSP workforce that provider employers have already experienced, even when offering on-site vaccinations and even monetary incentives to get those vaccines, they know that there's going to be pushback among the workforce, and that puts them at risk of losing even more employees if they have to comply with the mandate, which they do now if they're subject to the facility-based CMS rule, the newest one that came out in November. That's one issue. Even if they don't have compliance issues at the employee level, this only increases their administrative burden and even administrative costs because there are many federal and state documentation requirements, attestation requirements, record-keeping requirements. They also have to keep the employee medical records separate from the other HR records. So it's just a lot more work and a lot more tracking, whether they're doing testing, tracing, contact tracing, whether they're doing screenings, whether they're requiring the COVID test results, whether they're requiring vaccination results. It's just more work for the agencies.
And so do you think it has a negative impact on the people that they're serving, the agencies that they're serving, because they are at risk of not being able to staff, right?
Right. The goal would be, of course, to have the employees vaccinated, and that would, of course, be a great thing for the beneficiaries and the clients, whether it's in home and community-based settings or the facility-based settings, because we want to keep everyone safe and we want to decrease the risk of transmission.
Right, exactly.
But if we can't do that, then yes, the risk comes back to that workforce crisis issue, and will we have an insufficient workforce base to serve the individuals both in the facilities and in the home and community-based setting?
Great. Thank you. Thank you for sharing that. So we'll go on to, I think, the next slide. Is that right?
Yes.
Okay.
And this is just a snapshot that you can come back to later. Again, I had mentioned the average hourly wage for the direct support professionals in North Carolina being only around $10 as compared with some of the hourly wages that we've seen during the pandemic in the retail and fast food industries, and how that has been a tough competition. Also, and again, we're keeping in mind that these state DSPs, state employee DSPs, have been earning $15 an hour since 2018. We can go on to the next slide. So what have we seen that's helped providers and beneficiaries and their clients throughout the pandemic? We've actually seen a lot of federal and state flexibilities, as well as laws and executive orders that have been helpful for us. So the first one that I have listed here is the Federal Paycheck Protection Program, and that originated in the CARES Act in 2020. That Paycheck Protection Program pretty much allowed provider agencies who we work with to take out short-term loans that were good for about 2 months, and it allowed them to maintain their staffing and operation costs. So not just the hourly wages, but rent, utilities, anything else that they needed. Could use it toward PPE perhaps, but it was one way to try to ameliorate this mass exodus and to keep some stability within the workforce for the provider agencies. And ultimately, as long as they maintained adequate documentation, they were able to get loan forgiveness, full loan forgiveness for these loans. So this was really beneficial, and we did have provider agencies take advantage of the Paycheck Protection Program. Something that worked sort of in tandem with that was retainer payments, but those were narrow. Those were specific to CMS-approved Appendix K waivers. Every state could apply for Appendix K waivers under their states of emergency. The Appendix K waiver are specific to our 1915C waivers that we have in North Carolina. That's the Innovations Waiver, the Traumatic Brain Injury Waiver, the Community Alternatives Program for Children, and the Community Alternatives Program for Disabled Adults waivers. It's all home and community-based waivers, and the retainer payments functioned similarly to the Paycheck Protection Program in that they literally allowed provider agencies to retain their staff and pay those staff even if they weren't being used. For example, because we saw, again, day program, temporary closures of day programs where previously a DSP was needed throughout the day to work with groups of individuals who came in for the day program. If those individuals were quarantined or isolated under executive order or otherwise, then the provider agencies had a mechanism for retaining that employee and continuing to pay that employee until the situation abated, until they could bring people back in or provide services within some other venue. The other policy flexibility that we saw that our state DHHS applied for through the Centers for Medicare and Medicaid Services was the 1135 waiver. Those are distinct but broader. They apply more to our overall Medicaid program, and those can only be triggered when we have a presidential declaration of a federal state of emergency and the United States Secretary of Health and Human Services declares a public health emergency. Once those two things are in place, then states can apply for the 1135 waivers. The Appendix K waiver will live on in our state and for 6 months after the public health emergency ends. As of now, that's going to be January 16th, 2021. That's the last federal extension that we've seen. But these 1135 waivers, because they're so dependent on the public health emergency status, will actually end when the public health emergency ends. So that's important to keep in mind in terms of the flexibilities that are available under them. Some of the Appendix K flexibilities that we saw were very specific to ICFI ID facilities and the home and community-based services. They allowed provider agencies to deliver services in different venues and to waive certain administrative requirements or defer certain administrative requirements, allow for relatives living in the homes of the beneficiaries to offer services or to render services and be paid for those services. The 1135 waiver had additional flexibilities that you can actually read about on the DHHS web pages when there's more time.
People can, unfortunately, because we would love to unpack it more, but telehealth and the enhanced rates you also identify as having a really great positive impact on the way services are delivered. So that's one of, and I'm glad you mentioned that. People can find out more and read more in detail. Go to the Division of Health Benefits, which is NC Medicaid, and you can find information on the waivers, on the flexibilities that were stood up. And in fact, it should be easy to find under flexibilities, I believe, or policies, or so you should be able to find that. But they can also reach out to the Provider Council, correct, to get further detailed explanation. I want to go back to John, because you two really tie nicely together. And we'll come back, Sarah, and let you continue to talk about some of the benefits as well as, I think, where we are, because that's where I want all of us to, where we want to end up is like, okay, where are we now? And what do we need? What do we need to be doing? And collectively advocating, which is why the coalition that Valerie is the chair of, I call it the tri-population, well, really now the quattro or quad population when we think about TBI is so important. And I know you're a member, John's a member, Curtis is a member, I'm a member. So I want to go to you, John. And before we go to you, I want to sort of share this sobering reality. And I shared this slide in the first presentation, but I want to bring it back up. And that is that a study of 558,672 individuals with confirmed diagnosis of COVID found that patients with IDD had higher rates of COVID-19 incidence than those without intellectual disabilities and with COVID, and were more likely to be admitted to hospitals. So without IDD and a diagnosis of COVID, and and were more likely to be admitted to the hospital. So if you had an IDD and you had COVID, you were more likely to be admitted to the hospital. Also, those with IDD and a diagnosis of COVID had higher rates of ICU stays, 14.5% compared to 6.3% respectively, and patients with IDD were more likely to die following a diagnosis of COVID than those without IDD, who also had a diagnosis of COVID. So I just want to be clear, the common denominator or factor is a COVID diagnosis. So a person with COVID versus a person with IDD versus a person without an IDD was more likely to be hospitalized, more likely to experience severe outcomes of that diagnosis or of getting sick as a result of COVID-19, and we're more likely, and the most severe is more likely to die. So I want to go to you, John. And I know you also have some slides that you will be sharing and talking us through. You are a strong advocate for making sure, one, that we understood that. And it goes back to your earlier conversation about, hey, people with IDD should have been in that first wave of priority when we had the different levels that we were prioritizing who would get the vaccine first, right? And you all made that case very strongly. And there were parents, part of our CFACs and so forth, that drove that message home, local and state CFACs. So we finally got it. I want to go to you now and tell us about, piggybacking off of Sarah's workforce talk. Tell us about why we should not end up back here again based on what we've always known that the data have shown, that the IDD population is a fragile population and should always be prioritized when we roll things out, including when we talk about how much we pay people to work in facilities and home-based care, how much we, where and how flexible services access is, right? Or are. Like, why is it taking so long? We always hear people say, for these numbers on the innovations waiver, on the wait list to go down. And then the 1,000 that we do have, we keep hearing CFAC members say that's not enough. So I want to shift it to you to take us through your slides and just sort of drill home even more this conversation about the population that the ARC serves and why they should always be a priority to us.
Sure. Well, and thank you. I've had this question asked me inside what we do and outside and just in population folks that I talk with, what's the pandemic doing to people with IDD? And my response is, it's the same problem. It's just a different day. The pandemic has certainly concentrated the concerns and the issues, but the problems haven't shifted at all. They've just become more pronounced.
That's right.
And that's really what it comes down to. And as we looked at things, we were talking earlier about limited access to critical equipment. The key one that we were looking at the time was ventilators because they were in such short supply. And the way people were rated, or for a triage purpose, if you got 10 and you only have 5 pieces of equipment, somebody is going to go without. And how do you make that decision? Well, the decision-making process, and this again, the pandemic shouldn't have brought this to the forefront, but fortunately it did, because the process said, if you had an IDD, 10 years down the line, what does your quality of life look like? And it was an arbitrary decision about, well, if you have, for instance, if you had Down syndrome, 10 years out, your quality of life doesn't look nearly as good as somebody who doesn't have Down syndrome. And yet, where do you come up with that decision? And have you spent any time with somebody with Down syndrome or autism or any other condition? And how do you make that determination for 10 years out down the road as a criteria for critical medical equipment? And fortunately, that determination changed. You brought up the numbers of people being with IDD being far more adversely affected. And they mirror not only the national numbers that we were working with, we have internal numbers for people in North Carolina that we work and have direct contact with, and those numbers are almost identical. And so it really connects us back to the problems we had before were bad.
Yeah.
Now, with the pandemic and having gone through this now for 2 years, all it has done is really floated those major issues more to the surface and said, okay, if we didn't have it fixed before, and we're now looking at some things that may be able to help us, let's make sure, for instance, telehealth and telemedicine, let's make sure those things are still available to us once the pandemic is lost. Let's don't lose the lessons. Let's apply them and see what we can do to make the world better for somebody with an intellectual developmental disability.
That's right, and that's a point that I think Curtis and I in our conversation in this, this is not a normal pandemic. This is not a normal disaster, right? And we sort of treat it like a natural disaster. We stood up Hope for NC during this, which was first stood up during the flooding down east and the aftermath of that, the hurricanes. And so this is really hit all systems, unlike I've seen in my lifetime, our systems be burdened and strained. And as a result, we know that there are people behind these systems. There are people who are in need of the services that the systems provide. And so I agree with you. We got to look at the policies and the flexibilities that we've stood up with the existing policies, the new policies created, the flexibilities that were stood up for the existing policies, and see what can help us not end up in this place when we face another pandemic. And we don't know what's going to happen with, this new variant, Omicron, and all of that. But what we do know, we know what has worked effectively where we are now. So I know, John, you have some slides. We're going to run through those, if we may.
Yeah, it won't take long. Go ahead and pull up
so we'll go ahead
one.
and start, and then we'll shift to a conversation about our social workers and our kids, and particularly the K through 12 system. I want to talk about the role that social workers, licensed clinical social workers in particular, can play.
Sure.
So, John, we'll go ahead to your slides.
The first slide that I brought out really talks about same problem, different day. And if you can advance through, I think we have a nice couple of title slides, gets us into what we're dealing with. And then the next slide through is the one that really is the money slide. One more. And keep going. There should be. I think all I'm getting is title slides.
Yeah.
That's okay, because I can talk us through that.
Okay, go ahead.
So here's the thing. Prior to the pandemic, we knew that there were 15,000 people waiting for services. That's in addition to the 12.5 that were receiving services. And actually that number keeps growing. And it hasn't slowed down. The growth rate is going to continue. We are still people are still moving into North Carolina. People are still being born with intellectual and developmental disabilities. It is ongoing and occurring. And when somebody is receiving a Medicaid waiver, this is pretty critical stuff. This is not just casual things, and this is a discretionary expense. So this is not a guarantee that somebody's going to get something, and when the money runs out, the money runs out. And so with 15,000 people waiting, these are people that, because of that, family members aren't able to work. They're not able to participate in the community. The cost of supporting that person outside goes up significantly. And so the wait list growing is we knew this before, but now we feel it even more so, because you can't just take it by itself. You also look at the fact that we don't have enough direct support staff.
Right.
Talked about that. The shortage of direct support staff directly affects the ability to address the needs of people on the wait list. And again, with appreciate the General Assembly giving us a wage increase. It was a huge thing, but it's a start. It certainly shouldn't be the end all, because we still have a hard time finding people. We knew that this shortage was going on in terms of the need. This has been going on for 15 years.
Right.
It's like building infrastructure. We just haven't been building the infrastructure. And now as the need continues to grow almost exponentially, to have the staff there to be able to meet the needs has been dire. Add to that We haven't had rate increases in this business in almost 20 years. There's no COLA, there's no rate increase. It has been the same, virtually the same rates for 20 years.
And John, when you say in this business, you mean in the direct support provider
direct support
position?
in the services business of what we do, those rates have not changed. And so when we try to hire competitively, not just for direct support staff, which is the entry level kinds of things, but even the higher level, we are not competitive.
And for people who don't know, people may know, but people who don't know, just give examples of direct support specialists.
Direct support staff would be
like
somebody, be like an LVN, somebody that works in the home helping a person. Entry level is bachelor's or a high school diploma. There's no other requirement beyond that. For the higher positions, you need to have a bachelor's degree at least. Master's degrees are good. But, you know, even in those higher qualified positions, we compete with hospitals, we compete with the local managing entity, managed care organization. I love the term LME-MCO. It took me 2 months to get that term down without.
Well, after a while, you won't. I mean, I was going to say July 2022, but now December 2022. After a while, you get to shorten it to Taylor Plan.
We get to be a TP instead of an LME-MCO. But even the state, we can't compete wage-wise with staff that we have hired and trained, and then they find a job that's higher paying. And so we have this literally a 50% turnover in this business. And Sarah can talk to that.
Is it just North Carolina, or is it across the country? Is it a problem across the country? It's a national trend.
A national trend. And as I talk to, because I'm the state exec, for the ARC, I have conversations with my counterparts across the country, and they share the same concerns that the agencies that provide the funding are able to hire where we can't hang on to them. And so you get this turnover and this drain that we just accept because that's the way it works. And yet at a 50% turnover, that's outrageous.
Yeah. And
it costs us significantly, and not just costing the agencies, but the impact on the people that we serve is overwhelming. And you throw into that the fact that here in North Carolina, we have the county contract realignments with the demise of Cardinal Innovations. We have Medicaid transformation that's coming up. That is a big piece of what we're doing. Just little things like the EVV installation for the electronic visit verification, all these things. And then you throw on it a pandemic where people can't go out, people can't connect. I mean, I have not had even a quarter staff in my office in almost 2 years. And that affects everything. So that's on the downside. There are some positives.
Right.
And that's on the next slide. And again, talking through that, the new budget gave us 1,000 waiver slots. Now, with 15,000 people waiting, we will outgrow that 1,000 in a year. That seems to be the case. We're growing about that fast. But without throwing shade on that, the 1,000 waiver slots is more than we have ever had. And so that's a huge step forward. We want to see more.
Right.
And the ARC's position is we're going to try and knock that down in 4 years. We want a quarter every year, but we'll take the 1,000 now and keep working to figure out better ways to make that happen.
Yeah.
The wage increase for direct support staff, it's great. At $15 an hour, that's a huge start because the starting wage was $10 to $12 an hour. At 15, that's a good start. But now we're competing with McDonald's for something that should be a professional startup, not just, we're bringing in minimum wage and we're going to lose you to Target or Walmart for those kinds of jobs. There was a lot of housing support because the providers that are doing work in those homes, in those direct positions, the system and the formula is lopsided, making it extremely difficult to provide the services and maintain the home in the process. And so there was a lot of money for the first time to help support problems that were created when we first went to the managed care system we've got, the LME-MCO system. That has been shifted. And that's been, 10, 12 years in the making to address those problems that started back then. And I got to say, as much as we're in the middle of a pandemic, it hasn't necessarily harmed us in the sense that we've been getting the retainer weights and the K waiver that Sarah talked about. That is the first rate increase we have seen in years. And that's amazing to us because for the first time, we actually have a little bit of breathing room. And the concern that I hear from not just the providers, but from the people that are receiving those services, what happens when those rates go away?
Right.
Are we back to where we were? And again, this means that there has been no increases, no COLA, no adjustment for inflation. Those numbers have been fixed for years and years. For the first time, we actually have a little bit of resource to help retain and to pay staff what they're really worth. And we've got some room to work. And then finally, and this is something that I've been arguing for a long time, once you start looking at the system needs to be expanded, and a lot of people say, ooh, we don't want to invest in that, but let's look at what this does. I mean, I have a background in organization and some economic development things that I've done over the years. For every dollar that is spent in North Carolina, for every dollar, $1.68 is generated in economic impact in the community.
Right.
So we're making 68 cents on the dollar. That's not a bad return on investment in this business because there is a federal match, and you start adding the 2-for-1 federal match and now the additional FMAP that adds even more to it. That's over $5 for every dollar North Carolina writes out for the IDD and the substance use and the mental illness and TBI systems, the mental health systems. All of that, when you put in the federal dollars that are matched into that, for every dollar we spend, it generates $5 in our community. Now, in terms of return on investment, that's a pretty remarkable number, but we don't usually think about that because we're generally considered an expense. Right. In the middle of a pandemic, we're a huge expense.
Yeah.
But stop and think about what the alternative side of that is, and that is we are also a huge economic impact.
Right.
On the level of Apple that's coming to the Raleigh Triangle area, on the level of Amazon, on any of these large investments, if you take 15,000 people who need services and include them in and look at the impact that brings, that's a huge thing. And these are things that we've been seeing and hearing in the middle of a pandemic. It says, wait a minute, what happens from the lessons that we've learned? What could we do differently? And what is the result of that? And that's where a lot of conversation needs to be had.
Right. And I'm wondering, and we're going to go, this is a conversation that's long overdue that we need to have, I think, to really talk about, like you said, where are we going to go? How do we get to where we need to be? And it's not an easy, there are other providers type or service providers that are basically saying the same. I'm hearing it from peer support specialists that the reimbursement rates, even though they vary across the state, what we're getting paid to do this. I'm hearing it. We're even hearing it from people who are CNAs who are providing services to people with comorbidities. We're here. So we have to have a conversation where it doesn't feel like one industry that's serving the same populations in many ways, or many of the same populations, one industry is being advantaged over another one. So how do we have that conversation? Where do we go so that no one is being left behind? And so I think that's another conversation because you've got, on the one hand, is it the industry that has the best advocates and active, and lobbyists and so forth? Or should we look at not letting that influence the decisions, but really look at, who's serving some of our most fragile, medically fragile and vulnerable populations. But we'll pick that up in a moment. Yeah. And we're so sorry there was some issue with the slides transitioning. Sure. So we do apologize for not being able to have your slides up. But I do want to now go to you, Valerie. We talk a lot about the impact that the pandemic has had on adults. And we also know that it's also impacted children in a lot of ways, and in particularly kids who were challenged with the whole social isolation piece when being able to go up the street, across the street or whatever, and hang out at a friend's house, hang out at the mall, hang out, at school, playing extracurricular activities was a way that teens dealt with their mental health needs, right? Socializing, engaging, although there are negative effects of that as well. But and then we also know that this whole virtual learning space was not good for all children, and that there's been some learning time loss for kids. And how do you deal with that? How do you deal with a lot of the issues that young people are dealing with, tethered to electronic gadgets and relying on social media as a conditioning tool, right? It can, telling them what the norms are. And we know about the implications, the negative implications of that. Instagram and Facebook have been in the hot seat and TikTok, all the social media platforms for not protecting kids enough, not having enough protections in there as we look at suicides tied to bullying, cyberbullying, tied to kids constantly being fed high doses of messaging on social media that causes them to question themselves, their self-esteem, and so forth. A whole host of things. We look at kids who had IEPs, who were used to having that one-on-one contact. And so we see that this too, as Curtis said, has been a perfect storm for creating and exacerbating mental health needs as well as substance use needs of our kids across populations, including those with IDD. So will you tell us a little bit about what role social workers play, what things have worked, and what things you're excited about in terms of the policies in North Carolina to support your workforce?
Sure. Thank you, Dr. Laws. So as someone who has a small child at home and the thousands and hundreds of thousands of parents and children who had to pivot very quickly last year during the pandemic and move everything virtually, it was incredibly stressful, not only on the children, but the parents who both lost their jobs or had to continue with their jobs and figure out how they were going to teach their children at home during the pandemic. So that was a very stressful year. So, of course, the mental health needs for not only adults but children increased over the last year. And a big part of what school social workers did last year was look for children and trying to locate the children who were supposed to be in virtual learning, whether or not they didn't have access to the computer right away, if they didn't have broadband services. Some children are moved from home to home. So a big part of what school social workers did last year was trying to locate and make sure that the children were safe. So that is, I commend the school social workers over the last year who have had to work very closely with the families and children to ensure that they were not only safe, but also receiving the food that they normally had received at home, at school as part of the school lunch programs. But as schools got back into session, school social workers are indeed burned out, stressed out because of their higher caseloads than they had before. The national recommended caseload for one school social worker per student is one school social worker per 250 schools. 250 students. That's the national recommendation. Last I checked, there in the state of North Carolina, there's one school social worker per 1,400 students.
Wow.
So there are definitely not enough school social workers throughout the entire state. So, and the resources in particular in the rural areas are even less. As we talk about, we're excited about parts of the state budget. There, $1 billion of infrastructure to expand broadband has been has been allocated, which is great for not only telehealth, but also for students who continue in virtual settings. That has been good for some students who have been bullied in person in school, where being in a virtual setting has been safer for them, in particular the LGBTQ communities or students who identify as transgender. So social workers have been working incredibly hard, and we are not only always advocating for more school social workers, but an increase in salary for school social workers. As you talked about, I know both Sarah and John talked about a workforce crisis or workforce shortage of direct service professionals. There is also a workforce shortage of behavioral health professions. And so to cover all of the behavioral health professions who are highly educated, highly trained, and licensed professionals include psychiatrists, psychologists, counselors, marriage and family therapists, and of course, social workers. So shout out to all of our behavioral health professions. Yay! So historically, nationwide, there has been a shortage of psychiatrists and psychologists. In particular, there's a behavioral health service workforce shortage in rural areas. And so as we have seen the pandemic increase and more people rushing to get services, I'm hearing from a lot of my members that their caseload is full, they're over full, that their wait lists are closed, and they're doing the very best that they can to refer out to other qualified professionals. So another issue that we're seeing is behavioral health professions leaving networks, so no longer taking insurance because of a little bit of what Sarah talked about is the burden of the administrative burden of being a behavioral health professional taking health insurance. But the other piece of that is the reimbursement, the low reimbursement historically for behavioral health professions. For example, social workers are reimbursed at 75% of the psychology Medicare level. So Medicare and Medicaid services sets the standard, essentially sets the benchmark for what behavioral health professions are reimbursed at. And so licensed clinical social workers are reimbursed at 75% of the psychologist Medicare rate, even though they're billing at the same codes, as well as providing equivalent services for the amazing education, training, and licenses in which they hold. So the burnout rate is high. So historically and chronically underfunded behavioral health safety net, as well as low reimbursement rates, high caseloads, turns to burnout and turnover in large provider organizations. So that being said, I think some ways that we can work together is for the state leaders to work very closely with behavioral health organizations as well as providers to come up with policies and a strong mental health infrastructure to continue to support North Carolinians. Because as Curtis and John and Sarah have all talked about, we have a workforce that we need to support in order to do the services that North Carolinians need. So that being said, there's a lot that social workers do. There's a lot that behavioral health professionals do to support North Carolinians, and we're here, but we need to be paid in order to stay in the spaces in which clients can therefore access those services.
That's right. That's right. And I just want to sort of underscore how important it is for us to have all hands on deck, whether it's licensed clinical social workers, psychologists, psychiatrists. It's important for us to have all hands on deck. And if they are billing the same code and doing the same work, then pay equity is important. So I do agree with that. And I want to underscore this. I want to share some data about children. Compared with the rate in 2019, there was a 31% increase in the proportion of mental health-related emergency department visits that occurred among adolescents between the ages of 12 and 17 back in 2020. So during the pandemic, there was a 31% increase in ED visits by adolescents. Also, during that same year, July 26 through August of 22 of 2020, the mean weekly number of ED visits for suspected suicide attempts among girls was 12 to 17 years, and that was 26% higher than in 2019. And then also, during February 21 through March 20 of 2021, the mean weekly ED visit counts for suspected suicide attempts was 50.6% higher among girls 12 to 17 years compared with the same period. Now, we don't have to go into the data and the surveys and studies that, survey findings and studies that are showing this correlation with a host of factors, including social media, including this whole social isolation, including feeling bullied, including being in homes that were not healthy in the first place, and then having to be closed up in the homes. And then the other point, again, is just underscoring this whole increase in suicide. So thank you guys for pulling those slides up quickly for me. So Valerie, I do think it's important for us to have that conversation about the role, the fierce urgency that we have in dispatching our clinical social workers and licensed clinical social workers in particular, because social workers are who a lot of these kids, including girls from marginalized populations, come in contact with first. Mm-hmm. They come in contact, right, with a social worker first when we talk about marginalized populations, especially when we talk about the Medicaid population. It's a social worker that they come in contact with. I also want you to address a bit this whole impact on families that social workers are witnessing, and then foster care and why we got to get our foster care plan right when we roll it out, because there are kids in foster care that we don't even sort of sometimes include in these conversations.
Right, definitely. So yes, in particular, most of the time, the social worker is the first point of contact when there is an issue for an individual. In schools in particular, there's more counselors than there are social workers, so sometimes they'll see the counselor first, and then sometimes that student will be referred out to a social worker or a psychologist or a psychiatrist, depending upon the level of need. But social workers, the core of the profession is for social workers to find the resources, understand the person and environment, and connect individuals with those social determinants of health, making sure that they have the resources they need in order to meet their not only basic needs, but to thrive as a family. So yes, Dr. Law is exactly what you said. A lot of what social workers do are also making sure that students, that young persons in particular are in a safe environment. And I know that domestic violence and child abuse and neglect numbers increased during the pandemic because everybody was in the same space at home, and there was less reporting. However, because people did not feel safe to make that reporting. They were seeing their social workers less. They weren't at school. Teachers weren't able to make those reports or see folks. So that was a big issue last year. So social workers are at the front lines, but they can only do so much when their caseloads are so high. So again, that goes to where we need to increase the number of behavioral health providers, in particular social workers, in environments in which young adults are thriving, and increase their salaries. Because again, as I talk to my members, I have school social workers on my board of directors, on my equity and inclusion committee. The burnout rate is high because of those high caseloads and low pay. So as a profession that is incredibly gifted in the work that they do, they, just like all of the professions that we've talked about today, need to be compensated for that work. And what you just said earlier is, how do we uplift so that one area, one profession doesn't receive more than the other? And I think that's a big part of what the coalition does, is we are a collective voice of organizations that represent providers, represent consumers, represent families, and so working together to advocate and lobby for all of these issues is a big part of what we do.
Wonderful. And you do it well. So glad to always share that space with each and every one of you. We are at the end. We will check to see if there are questions or comments that have come in. But as we wrap this up, I want to start with you, Curtis. If you had the ears of any and every person that could wave a magic wand and make one thing happen to improve outcomes in the substance use space, what would that one thing be? And that's for all. I know it's hard, but what would that one ask be that you think could have transformative significance and impact?
Well, Doctor, I can't limit it to one thing, but I'll try to limit it to a couple. So first and foremost, again, I go back to the importance of that face-to-face social interaction that is so desperately needed in the recovery community. And if we can figure out how to have, football games with 100-something thousand people in attendance and do that safely, then I feel like we should be able to figure out how to provide treatment, how to have mutual aid group meetings and things for, 15, 20, 30 people at a time, and keep everybody safe. We need protocols for vaccination status and masks or no masks. A lot of these meeting spaces are very small, and you're already dealing with a vulnerable population. So we need to make sure that folks are getting what they need, but getting it in a safe manner. The fact of the matter is that in the system as a whole, despite the tremendous need, our system is still kind of focused on that acute care model and treating substance use disorder like a broken arm, so to speak. Just put the cast on, it'll heal, and that person will be all right. When, the data already, the evidence shows that people need recovery support. And so if we could wave that magic wand and shift things to more a focus on providing those supports, then, we can make a huge dent in those return to use numbers.
So thank you so much, Curtis. Thank you for your 1 and 1A, B, and C. I want us to go quickly through these, though. So please, I want just one thing, because we do have, I understand, a question and comments that we will conclude on. So, but I want to go around really quickly. So, Sarah, one big ask. What would that be that could have significant impact?
I think we touched on it today in other speakers, would be the rates. The reimbursement rates really affect both the provider agencies and the workforce crisis issue, and the ability to render enough services and have enough staffing to provide adequate and quality services to all of the beneficiaries.
And what is the desired or an acceptable reimbursement rate to get to, at least as a floor?
I think it really depends on the service line. It does. Depends on the service line and the context. But it's really about having enough to cover operational costs, to cover benefits, to cover the cost of the staff turnover that we talked about, and also to pay adequate wages that are competitive and enable the provider agencies to keep their employees, because they do invest a lot in training and other aspects of hiring.
Well, I'm going to tell you, I also hope we have accountability in there, because I hear from people from all over the state, as you know, who are in different roles. And one person said that make sure that there is accountability for providers that are exploiting this space, this workspace, that they and in particular, I'm thinking of a person who sent an email to, I'm not sure if I got it from Cody or if I sent it, but Chief Deputy Secretary, but someone had sent an email some kind of way, I got it. And it said that they worked for a provider that they wanted the state to investigate, because the provider was taking trips and doing this, that, and the other, and wasn't paying their workers hardly anything. But yet, though, they were making all of this money, that they felt and was sort of exploiting and using the workers. And so we need to look at the system across to make sure that that's just one bad apple that's not spoiling the whole bunch. So I do want to bring that. John? On the heels of that.
Can I speak to that concern really quickly?
Well, let me let John go because he might do it really quickly. John?
Well, first off, accountability is definitely high on the list, and definitely in that pot of money that we're talking about, a little bit set aside so that the next storm that hits, we've got something in the tanks to work with.
Yeah.
But if I had to give you one thing, invest in the IDD community. See us as a value, not a burden. The minute we shift the gears from a burden, which is pretty much how we've always been approached, and see us as the value that we truly are, that shifts everything. We're no longer an appropriation. Now we're a value and a benefit to the community, which we really are.
That's right. That's right. Valerie.
So I know a lot has been covered, especially around reimbursement. So I'd like to do a shout out about expanding Medicaid in North Carolina. Yes. We are all disappointed that did not happen again this year. That's been on our legislative agenda for years. North Carolina is one of 12 states that has not yet expanded Medicaid. And there are 1.1 million North Carolinians that do not have health insurance, and Medicaid expansion won't fix everything, but it will inject some funds into the state, in which will not only provide funds for medical services, but as well as behavioral health services. So my plug is going to be that big ask is we will continue to advocate for Medicaid expansion in North Carolina as long as I'm in North Carolina.
That's right. I'm with you. That's exactly right. And we need to have a whole conversation, another discussion about that. We need to have another segment on Medicaid expansion and why it's so important. I'm going to let Sarah make her comment on the comment about the accountability and the email that we received from a worker in the system who said, hey, who was basically advocating for higher wages for them, because from their vantage point, they were seeing this person they worked for living quite well.
Yes, thank you, Dr. Laws. I just wanted to note that inherent to the Medicaid program, first of all, there's a lot of what we call program integrity activity and many audits at many levels to ensure, whether it's a prepayment review or a post-payment review, we have a lot of different mechanisms for preventing fraud whenever we can within the system. And we have the DOJ and other entities who really work hard on that. But also, even in the new legislation that John referenced, where we've seen an increase in wages for the direct support professionals, it's really going to work as a pass-through to the home and community-based and ICFID providers. But they will be held accountable to passing 80% of their increased rates through to the hourly wages for their employees. And
Good.
There will be documentation requirements, and that's all legislated in our new state budget.
Yeah, and I just want to be clear, they weren't indicating fraud for the person they were working for. They were indicating that the person was, I guess, making a lot of profit, that there was a wide profit margin, and that they were not paying their workers. So they didn't suggest fraud. They simply suggested, and it was part of the push for increased wages for direct support. And that was their argument, was we deserve to be paid. We're seeing our employers doing well, and we're not, and we're doing all the work. That was that. But I agree about the program integrity piece of it. That's for North Carolina, I think we do a relatively good job and catch the bad actors, the ones that are committing fraud. So we're going to quickly go to the statements and the question. This is from Vanessa Irvin. Thanks, Sarah, for the detailed review providers and members are experiencing North Carolina. And Vanessa also asked the question, how will we protect the workforce? Without them, the system will crash. And this gets to, I think, the point of the email that we had received, that the workforce, the workers want to be protected. The workers, the people that are out there going into homes, not the agencies that are sending them, but the people that are going into homes, working in facilities in these low wages. And so I would say to this, and John and Sarah can add, that we're on that's exactly why we are now, is focusing on the workers. Anything else y'all want to add to that, to answer that?
I have a thought, Don.
Okay.
We need to create a living wage and a career path. so that not only do I have a place to enter with sometimes minimal education, but that it will actually lead someplace beyond, so that I do have some idea of where this is going to go. And all of that, again, it's an investment in the infrastructure of services, but that's kind of critical. If we don't begin investing in that, we're going to see not only more of what we've had in the years past, but it's going to get worse.
That's right. That's right.
And also, we have seen throughout the pandemic, we've seen problems with the physical health and the mental health of the DSPs, because they have been, particularly in any of these 24/7 facility-based settings, they've been carrying the burden. The ones who have not voluntarily terminated their employment or have shown up day in and day out, they've had to cover the shifts for the individuals who were no longer there working, and that has really put them at risk. Their jobs are both emotionally demanding and physically demanding for the direct care, so that's very important to support them in that way as well, to ensure that we don't have high turnover and that we can actually fill the vacancies within the agencies.
That is such a great point, Sarah.
That's a hard reality. I've had conversations with some folks at state, not in your division, but in other departments and with other, the LMEMCOs, where the comment has been, well, we're shorthanded because of the pandemic. Well, that's a lovely excuse, except for we are still held to the exact same standard of performance, whether we have staff or not.
Right.
And so it's like what Sarah said, when we're shorthanded, the burden falls on the folks that are picking up the extra shifts, and physically, emotionally, mentally, spiritually, we are tired.
That's right.
After 2 years of picking up that extra burden, and it doesn't look like it's going to end anytime soon. But that's the commitment that this group of people has made.
That's right. Yep, exactly. Next question or comment, if we have one. All right, so from Phil Landis, what have you seen in the North Carolina veterans community in regards to elevated mental health and substance abuse disorders, along with homelessness over the last 18 months in this population? I mean, that's an excellent question. And we did have a presentation or a segment that was done by the Governor's Work Group, Women's Veterans Council, thank you, Women's Veterans Council, I couldn't remember it, and they addressed in that series, in that particular special segment, some of those questions. But I want to say, yes, we're seeing an increase, and particularly the ones that are served through our system, which are those who do not receive veteran benefits because of their discharge status from the military. So they were discharged with maybe other than honorable discharges. And many of those were as a result of mental health and substance use conditions, which still sort of like just blows my mind that that you can provide your service as a veteran and because you have a mental health crisis or substance use crisis, depending on the severity of it, end up with an other than honorable discharge that reduces the types of services that you can receive through the VA and through military and veteran affairs. And so we do look at that. We serve that population. We have Jeff Smith on my team is committed to doing that work. So yes, we are seeing increase in needs, and particularly around the homeless population of veterans and also those with mental health. But you should be able to go on the Governor's Institute, and it's too much. I think I'm detoxing now from all that sugar that I had from Thanksgiving on through Saturday, the cakes and the pies, because I'm sort of foggy today, but I'm sure that's sugar detox. But yeah, you can go on the Governor's Institute website and find the archive or the recording there, the video recording there. And as we go out, I just want to thank everyone. I want to thank our panelists. I want to thank Curtis from the Alcohol and Drug Council of North Carolina. I want to thank Curtis Taylor. I want to thank Sarah Fowle, who is with the Providers Council and also Chancellor Associates. I want to thank John Nash, who is with the ARC, and Valerie Arndt, who is with the North Carolina Association of Social Workers, and all the wonderful work that you all do individually and collectively in making up the mental health DD and Substance Use Coalition, as well as TVI. So I want to thank you for this conversation that we've had today, which has been really important. We know that we need to continue to have this dialogue, and most importantly, the reason why we're having it through this format here at UNC TV, streaming it live on Facebook, and it will later live among the archives of the different ones that we've done throughout the pandemic, starting back in 2020 when we could no longer go out and have our face-to-face town halls. The reason we're doing this format and we're continuing to do it is because we do believe in transparency at the Division of Mental Health, DD, and Substance Abuse Services. We believe in answering and addressing the hard questions that come before us and making sure that the people that we serve, we consider ourselves public servants, the people that we serve have a format and a medium to get their questions addressed, and that we can reach a wider segment of the audience than we can maybe doing meetings internally, as well as some of the meetings in the way that we've done them externally in different areas. By having this format, we can reach across the state. And so we thank those of you who continue to join in and participate and listen in when we have these virtual town halls or panel discussions. If there are topics that you'd like for us to include, please reach out to us at the division and let us know what you'd like for us to address. Continue to tune in or join our monthly provider calls that we have on Thursdays. I think it's the third Thursday of every month. And then also our monthly consumer and family and community call that we have also to address and answer questions with our partners at Health Benefits. I want to thank the team here at UNC TV, who always provides amazing technical support and production support and allows us to come into these beautiful studios. And none of this would be possible without my right hand, and that is Suzanne, who always make sure that we have everything we need to roll these out in a very professional way. And that includes reaching out to all of the panelists and making sure that the promotions are sent out and done. So thank you, Suzanne, for the work that you do behind the scenes. And we want to leave by just saying, on behalf of our interim division director, Deepa Avula, we are there to serve you, and we are working hard to try and create a system that improves outcomes and doesn't create additional burdens for those people who rely on the services that we provide through this public mental health, DD, and substance use services system. So thank you all, and again, we hope you will stay in tune to what we are doing at the division as part of our engagement strategy. Take care.